How are
I
you?
like that
Good
shirt.
evening. Good evening, good evening, good evening, and welcome to Couch Conversations with the Doctors, where true health is wealth. Want to remind everyone to come on in, come on in. It is Monday night, and Monday night is Couch Conversations with the Doctors. Once again, what is Monday night? It's Couch Conversations with the Doctors, where you learn that true wealth is health. So come on in and remember to and share once again. We're going to go around our table as we always do, and we're going to introduce our esteemed guest that is here with us on this evening. For some reason, I'm hearing a whole lot of feedback. And let me, while we're working through our technical difficulties,
Much better.
okay, there we are. So we're going to go around the table as always, and we're going to introduce our esteemed guest. I'm going to start with the urologist of the stars, the man who can fix it if it can't be fixed, then it doesn't exist. That's our very own Dr. Terry Mason. Dr. Mason.
How are you, Nikki? That's an interesting introduction, but I'm going to let that go for right now. And I'm grateful to be here with my esteemed colleagues, and I'm sure we'll have a wonderful conversation about a very, very important topic. And I'm hopeful to be blessed to be able to make a significant contribution.
Outstanding, outstanding. To the man who says I threaten him to be here on every Monday night, but he seems to be on time. That's our very own Dr. James Miller. Dr. Miller.
Good evening, everybody. My name is James Miller, and I'm a retired physician. Work practices mostly on the west side and suburban areas, but did spend some time on the south side during my clinical years. Um, Currently retired from clinical practice, but still trying to heal the community. So we're happy to be here on this forum tonight. Hopefully, we can answer some questions and maybe offer some good advice that will help somebody to be healthier.
Outstanding. I want to say hey to Karen, who is here with us. She says, good evening to everyone. Good evening. And she says, hashtag sharing. To my colleague and coworker who is here with us, who wants to leave me and go to Sun and Fun where it's warm at. Want to say hey to Dr. Douglas Graham. Dr. Graham, why don't you introduce yourself to everyone that's here?
See, in my generation, there was a song called Follow the Sun. So I'm just doing that. So, hey, well, listen, I'm also like Dr. Miller, retired physician. I worked in the western suburbs for about 30 years. And I also spent 2 years in Washington, D.C. working in the congressman's office. And it's a real honor to be here. And I'm going to try and answer your questions if I can.
Outstanding, outstanding. To the art connoisseur who has the best frames ever. That's our very own that's our very own Joseph Harrington. Joe Harrington.
Good evening, everybody, and I'm blessed to be here with my esteemed colleagues who I've become virtual friends with. Some I know I've met in person, some I've had a chance to spend time with. I've had an interesting career. I actually, listening to people, wanted to mention that the first 5 years of my professional career, I spent working in North Lawndale. So I know the West Side, but I'm a South Sider. But I guess in general, I'm a Chicagoan. Most of my career was in healthcare and public health. My last two jobs, I worked for Dr. Terry Mason when he was Commissioner of Health. I was an assistant commissioner under him. Left there and went to the state health department, where I served as the regional health officer for Cook County. And I'm again glad and happy to be here. One other thing that I will say, and it goes with the introduction you gave to Dr. Mason, and you talked about him fixing things. And they say if it ain't broke, don't fix it. If you're doing the right thing, keep doing it.
Absolutely, absolutely. To that chef extraordinaire who is also an outstanding family practice medicine and infectious disease specialist, our very own Dr. Bonnie P. Thomas. Dr. P.
Well, I'm an internal medicine doctor, Nikki, but I appreciate you trying. But yeah, I'm extremely happy to be here with my colleagues, and thank you and the congressman for creating this forum for us and for the community. I think the more we know, they say you can do better when you know better, and unfortunately, a lot of our patients, they are not as informed as we want them to be, and so oftentimes they don't know what they should and shouldn't be doing. And so I'm happy that this forum is going to help to improve that.
Outstanding, outstanding. You know, I left my notes on my desk, and sometimes I have to look back at them. I didn't have them, so I said, I think I can guess my way through this. We've been here a while, so I thought I could get my way through this. But nevertheless, it's an MD behind your name, which means you can fix it.
So
if it needs-
Nikki, you deserve the benefit of the doubt, because both Tony and Maya are both family medicine. So I can see where you just said, "Oh, it's all medicine."
Right. Right. Dr. Maya Green will be joining us a little later, and so will Dr. Tony Hampton. I want to say hey to Jack Lynch, who's here with us. He says, good evening, team. And Dorothy Murphy, who was here. And she says, good evening to everyone. Had a great time with her on last night. She was out supporting healthcare once again, as always. So I want to say thank you to all of you guys who are here. December 1st was World AIDS Day. And in celebration of World AIDS Day, we're going to have this conversation talking about HIV and AIDS. And Dr. Pete, you've done a lot of work in this field, from the Core Center to near North, to all of the places that you've been and all of the places that you work, from Cook County. You know, I want you to lead this conversation on tonight as we have this true conversation about HIV and AIDS. You know, in our country, we have some startling numbers. Even though the numbers are coming down, there are still people testing positive. And believe it or not, gang, just want to make sure that we share some really good statistics with you on this evening. There's a climbing rise in African-American straight women when it comes to numbers rising with HIV. So we want to make sure that we share those numbers with you just as well. But right before you start, I want to say hey to Tamika Thomas, who was here, and she says good evening to her uncle, Terry Mason. So want to make sure that you know that Tamika is here with us on this evening. Dr. P, take it away.
Yeah, Nikki. So, you know, you were right. I spent most of my career practicing HIV medicine. Even when I was training, I trained at the Illinois Masonic Medical Center and had the opportunity to practice with the Triad Group. And part of that Triad Group was David Moore and David Blatt. Shout out to them. They were county docs too. And went from there to go on to work at Cook County and also to work at the Core Center. So cut my teeth over there, and just some tremendous doctors, and not just doctors, but nurses and social workers, and place is incredible. I think it's the largest freestanding HIV treatment center in the world, I believe. Thanks to our former chief, Dr. Terry Mason, made sure that we was meeting all the goals and making sure we was in the community. So I'm happy. I'm at Howard Brown now, and we're still doing some tremendous work in the community. Also with Dr. Maya Green, she's going to be on a little bit later. But World AIDS Day started in 1988. It was a way to remember, to bring awareness to the HIV pandemic that's happening. And I think oftentimes, because we don't talk about it, people make this assumption like it's over with. And I can tell you, even during the pandemic, I probably diagnosed one person a month with HIV. Now, that may not sound like an impressive number, but just imagine we were shut down.
Yeah.
So imagine being shut down. So who was contracting HIV and did not have the opportunity to come in? So I say that to say that the pandemic put us behind the 8 ball. And even though we are reporting numbers that the incidence is going down, I would say that should be with an asterisk, because we really don't know that post-pandemic, right? So here's some numbers for you. There were 34,800 estimated new HIV infections in the United States as of 2019. Now, y'all remember, that's when the pandemic started. Now, the question is, so we took that 40,000 people, 40,000 people were diagnosed in 2019. Now, did that number go up or down? We don't have the data to support that. That number is down compared to previous numbers, but since the pandemic, we don't know. And I can tell you that because a lot of the resources were diverted, and I'm not saying I disagree with it, but it was diverted due to the pandemic. We needed all systems on deck to help keep the pandemic from killing a number of our citizens. But now that means we have lost some ground regarding the new therapies and new research. But I will tell you this: we have more resources now to treat HIV than we ever did. But as with many things, the biology isn't the problem. The problem is these social conditions that many of our patients live in, right? We got poverty, we got racism, we got all those things that disconnect our patients from our healthcare system. And so no matter how good our medicines are, we have injectable medicines, we got great medicine. We have one now that's coming out, and you're gonna be able to get yourself an injection every 6 months. We have one now that is every 2 months. You can come in, get an injection, and come back every 2 months. Now, I'm just telling you, when I was a second-year resident, we would routinely have a certain census of patients on our ward, right? So we might have 20 patients. In the morning, we might have 10 because either 5 did not make it through the night or the other 5 went to the ICU. So we went from that to now, really, if you're taking your medicine, I always tell my patients, you're going to die from something, but it won't be HIV. And that's so encouraging because I know from which we've come. And there's so many friends of mine, my own brother passed from complications of AIDS. And so, this is a life mission work for me. And I'm happy that everywhere I went, I was able to use all of my skills and talents. And so I always had an HIV clinic. Even my clinic on the South Side, I had a practice there, but I also practiced at the Core Center. So I said all that to say this should be an interesting discussion because, we're still talking about issues like social determinants of health that prevents people from connecting into care. We're still talking about things like stigma, right? I went to an international stigma conference because for some reason, when you mention HIV, people put a judgment on that as if you did something. And we don't do that to diabetic patients. We don't do that to heart failure patients. We don't do that to high blood pressure patients, but we do that to patients with HIV. And that keeps people from accessing care. So people say, well, okay, why do we care that people stigmatize? Because when you stigmatize, people don't want to get care. They don't want to come in, right? Some people say, I'd rather not know. And so, and unfortunately, there's I would say a stronger stigma in communities of color. And they're already dealing with so many other challenges, but the stigma keeps people from accessing care, and it keeps people from accessing care in a timely fashion at a time when we have more resources for people than ever before. So, and then also I would say there's stigma even in the LGBTQ plus community. So that's another thing that keeps people from accessing care. So this idea that just because you're in the LGBTQ plus community, that means that you're automatically HIV positive, or when in fact, Nikki, to your point, besides men who have sex with men, the highest growing group of people who are contracting HIV is African American women, and a lot of our women are unaware of this. And whenever I go and talk someplace, I always remind people of this. So in Caucasian men who have sex with men has a 1 in 16 risk of having HIV, 1 in 16. Hispanic men who have sex with men, that's 1 in 8. African American men who have sex with men have a 1 in 2. That take 10 men who have sex with men, black men in a room, 5 have HIV. So that is a huge challenge, and we're up to the challenge, but it's like we've always said, you got to put the necessary tools in place. The medicine is important, the science is important, but those other things that keep people from accessing care, even down to providers that look like them, right? That can speak the same language. We have a medication out now called PrEP that's 99% effective in preventing HIV. Why isn't, but only 18% of people that should be on PrEP is on PrEP? Why? Right? Because there's all these other things that people are dealing with, like paying them bills, paying them mortgage, unstable housing, all those social conditions. And that's why when we deliver care for HIV medicine, it's really a team of people, because we got to make sure you got a place to live, got to make sure you got food, because all those things can interfere with you coming in to get your blood work done, coming in to get your medication. So we make sure that all those things are taken care of, which requires funding. It requires money to pay for all those, I don't call it peripheral service. Those are services, because we act like as if, okay, the doctor, that's not peripheral services, but having a place to stay and having somebody that's going to connect you to housing, that's real services. So I'm going to stop and hopefully get some comments from my colleagues, and then we can start entertaining some questions.
Okay, go right ahead, Joe.
Yeah, I have a question for Pete. I don't have a comment, but I do have a question. I think it's important for the people watching and listening to know the difference between HIV and AIDS, because people may confuse one with the other. HIV is what causes AIDS. AIDS is something different. So could you go into an explanation of that so that people have a basic understanding? Because more people have HIV, carry the virus, than actually have AIDS. But everybody that carries the virus could develop AIDS and can transmit it. And so there's a difference in why people should take drugs too, based upon where they are.
Absolutely. Yes. And that was Mr. Daniels' question that he had sent in. So, Mr. Daniels, Joe Harrington asked your question for you, and Pete's going to answer it. Go right ahead.
Yeah. So in a really simple way, so HIV is called a human immunoimmune virus, and it is the virus that causes AIDS. AIDS is the advanced disease as a result of the HIV virus. In the discussion, like HIV causes AIDS. AIDS is the advanced disease. It is the immune deficiency. Acquired immune deficiency is the actual acronym, if you want to call it. But it's basically the HIV virus takes over the immune system. And once the immune system drops so low, that's when you have the diagnosis of AIDS. You can have HIV and have a very strong immune system. Those are people that are taking medications. So that doesn't mean that you don't have HIV. You do have HIV. If you stop taking the medication, the immune system will become low enough eventually to actually develop the acquired immunodeficiency syndrome, which is called AIDS. That number, by the way, how do we know if you have AIDS? Usually, by the time you have a very severe immune deficiency, you will develop symptoms. And it's usually just frequent infections. It might be thrush in the mouth. It might be pneumonia. It might be stool infections. But biochemically, we diagnose AIDS as someone who has a CD4 count below 200. The Department of Health and Human Services say 200. in my clinic, you our assay is really sensitive, and so we don't, you're undetectable under 20. So we don't. If you have a CD4 count, which is your T helper cell, if you have a CD4 count of 150, according to the Department of Health and Human Services, that is a diagnosis of AIDS. We don't diagnose you until your CD4 count is much higher than that. I'm sorry, much lower than that.
Thank you so much, Dr. Thomas. And let me just congratulate you and all the people that have been working tirelessly over the years. I remember early when I was a resident at Michael Reese in the 80s, HIV or AIDS was 100% fatal. 100% fatal. Everybody that I saw back in 1983 that contracted AIDS died. And we've gone from that, and you can expound on that when you respond, but we've gone from that to a much better state. We've gone from anytime we saw a man who was thin or losing weight, because oftentimes that was one of the early things that we saw with people. So how do you reconcile the fact now that we have so much available for people? And if you could comment on whether or not they have to pay for it or not, but yet we still have a problem. What do you think are the barriers for people today to getting the treatment that can save their life?
Terry, that's a good question. So I tried to allude to it earlier, which, if you look at our patients who have trouble with managing their diabetes, who have trouble managing their heart failure, who have trouble managing their hypertension, there's a common thread of social conditions that allow managing a simple diabetes or a simple high blood pressure that makes it much more difficult. And so that same thread, those social determinants, impact HIV also. The only thing is just the stakes are much higher now. And that's like depression, all these other issues, that anything that keeps you from taking that pill or that injection, anything we try to address, substance abuse. So again, if you come into an HIV clinic, there's a team of us. It's not just one person. There's a substance use counselor. There's a nutritionist. It is the formula for if you ever had an ideal clinic. Like, this is it, because I don't have to be the nutritionist. I don't have to be the counselor. I'm just doing the medicine. But I know that when you leave my office, you're going to talk to Jimmy, and Jimmy's a substance use counselor. And they say, well, Jimmy doesn't have a drug problem. We want to make sure Jimmy ain't got a drug problem. Because why? The minute Jimmy stops taking that medicine, then game over. And it's not game over right away, but you don't lose your immunity right away. But just that we try to make sure that you're getting the gamut of services. And I have my colleague here. I need you to tap on in. But Terry asked a great question, like, with all of the resources that we have now, Cabenuva and Apretude and all these injections, like, why are we still having a problem? Like, why are we? So I was just talking about the social determinants of health, but I would love to have you to tap on in.
Hey everybody, sorry I'm running a little late coming back in, but I came in at a good time because part of the work we do addresses why we still have that problem, right? And at the end, Dr. P, you said it, social determinants of health, but also you're right, you brought up all the evolution and the advancements we've had in medication. What we have not advanced is our language regarding HIV, what it is, and we have not advanced in community what is it, what it's not. So I'll give you an example. I don't know if you all remember, there was when COVID first, when we were saying shelter in place, stay home, basically the city shut down, and there was this party that a teenager threw, unaware of the shutdown. And many people have their opinions. The bottom line is, no one communicated to that teenager in a language that the teenager could understand what was going on. We posted it in a lot of ways, and that really highlights the importance of multiple ways that we communicate to multiple, people, which I think, the city then did a great job, which is develop these ambassadors and brand managers and got people that age to say, okay, here's the information, here's what we want to say. Now, how would you say that? And so if we don't do that, and if medical providers are going in places saying HIV is a disease of the other, only these people get HIV, and thinking like that, then the patient who's coming in looking for an expert, right, is going to believe it, right? The other thing we don't do that, and so if you look at the recent data from the city of Chicago, and not only the city of Chicago, all over the nation, right? HIV looks different in different communities, right? What's happening in those other communities? There's so much conversation being had that it is not at all jarring to anybody if I walk up in an area and say, hey, yeah, blah blah blah, today I'm going to go get tested for HIV, I'm going to go do these things, and yeah, that's what I'm doing today. It's not at all, nobody's thrown off, because the conversation happens every day. It happens in those 23 hours and 40 minutes they're not in the provider room. And that's where most people get their culture. That's where most people learn in their tradition. And that's where most people subscribe to their ways of life. So as soon as we start having those conversations at the dinner table, at other places, and we always talk about normalizing it, right? Instead of ostracizing it. And so as soon as we are able to better do that, I think we'll see a change. Dr. Mason, I think I saw you come off mute.
Yeah. I was just going to follow that up with, who should be tested for HIV today?
Dr. P, I want to answer that, but I know you want to answer what you want to do.
No, I was going to comment about your previous comment, because I think that's so on point. But Terry, I would say, if you're having sex, you should be tested for HIV. And it's not on whatever, like you think it's their problem, it's whoever problem. If you're having sex, you should be tested for HIV, and the CDC has a very clear, it's actually a opt-out, a lab test, which means that your provider does not have to ask you to get an HIV test. They can just include it in your labs as they should, though, right? Because again, like you said, we have all these resources, but we can't use the resource if we don't know you exist. If we don't know that you're positive, we can't use the resource. And if we don't know that you're positive, you might be unintentionally spreading it to other people. So, yep.
And then to dovetail off of what Dr. Pete is saying, and this is how I say that to providers, I say, hey, 13 to 64, it's recommended annually. So when I'm ordering your hemoglobin A1C and your thyroid test, everything like that, I'm pushing that button. And when I'm talking to patients, I say, here, you're here for your annual exam. Here are the labs. One of the tools that I offer to providers is I like to throw it in the middle, because there's a stigma when providers say, oh, we're going to order your lipids, hemoglobin A1C. I get vitamin D on my patients, thyroid. We're going to order a prostate screening, the PSA if you have a prostate. And then we're going to order HIV. You know what I'm saying? We're going to order hemoglobin A1C, we're going to screen you for diabetes, high blood pressure, cholesterol, HIV, liver stuff. We're going to screen you for, it's in there. And we're going to screen your thyroid. And so the patient is like, okay, that's the testing battery I'm getting. Okay, the other thing we've done at our institution is there's an annual lab order set, and it's just in there. The other thing I say to some people when they ask me who, I say, well, HIV stands for human immunodeficiency virus. So it's a virus that attacks the immune cells of humans. So if you have an immune system, you need to get tested. Just like if you have a pancreas, if you get tested for diabetes, if you got a thyroid, you get your thyroid tested, you got an immune system, it's one of the systems that we test.
Yeah,
Can I just sort of raise a point that I'd like to have Dr. Pete and Dr. Meyer to to talk about a little bit, and that is, we talk about those that are infected as being people that we focus on, but I think that especially in the African American community, how do we get to the point that we are now beginning to put that conversation in places other than just talking to people who have been diagnosed, because that in that segment lies a significant part of these problems and part of the things that contribute to the statistics that you talked about in terms of Black men, one out of two being HIV positive. So what I'm saying here is communicating with our community, communicating with people, and how do we open that up so that now people are not afraid, people are not persuaded not to even consider these tests or even think of the notion that I would rather not know. I mean, these are just bad kinds of things that create a public health problem. This is not an individual problem; it's a public problem. And so, how do we? When there's a public problem, the public need to be involved in the process.
Yeah, Maya, you want to? Maya, I can't. You're muted.
Thank you, Dr. P. I'm trying to not be as but this is something I'm very passionate about. So going back to Dr. Miller, going back to what I was saying before, it's how we're having the conversation, right? What we saw when in previous iterations of trying to develop people in care, it's what we're saying. So if I tell you HIV is a disease that gay people get, IV drug users get, first of all, I'm not speaking factually, right? Because we know that 87% of Black women who get HIV get it from their heterosexual male partners, right? Not any and they're not identifying as gay, right? The second thing is really taking the focus off, because people are.
Maya, I want to stop you for one quick second, and I want you to repeat that last comment you said one more time.
87% of Black women who get HIV get it from their heterosexual male partners.
Repeat that again.
87% of Black women who get HIV get it from their heterosexual male partners. Meaning I don't identify as gay. I'm not intimately active with other women. I'm a woman, and I'm only intimately active with my male partner. And so those people are getting it from their heterosexual male partners. And so if I'm saying you have to identify, so if I'm building the box, that's one thing that in the medical industry, and I get it, a lot of times we build it to help us classify diseases, right? But if I build a box and I say, these people, this is my little box, and you have to identify as gay, you have to identify as a drug user, you have to identify. Now, if I name it, and all the things that, people that community shuns, right? And I say, if you identifying, you are accepting of being in this box, then you should get tested for HIV. Then you have access to PrEP. PrEP is a medicine that you can take to protect your body against HIV if you're ever exposed. Then, so that builds a barrier in itself, right? Because that means now you have to take on all these things that are typically ostracized in certain communities before you come in and say it. And that's a leap a lot of people can't make for a lot of different reasons. It's a leap that has cost some people their lives. So ain't nobody interested in fitting in my box. But if I say, you got an immune system, you was born with an immune system, I got to screen it. That's what the guidelines say, gold standard, and I go like that. That's how I think it can be communicated. And if people aren't ready to tell me about what kind of intimacy they're experiencing, but as a medical provider, it's my duty to ask. I do ask, but I ask like this. how is your nutrition? How is your work life? How is your home life? How is your love life? And people say, huh? Because not a lot of providers talk about it. I'm like, okay, well, get drilling down. I'm about to ask you, are you having sex with people who identify as men, women, or both? And what body parts but you build it into all of it. Do you smoke? Do you have a job standing up or sitting down? Are you looking at a computer? It's all the questions. And a lot of patients, I will tell you, a lot of times, the first time, and then I'll be like, well, when I ask these questions, people say this. They say, yes, I do this. No, I do that. And then one of the options I'm open to is none of my business. So if I ask you about your sex life and you tell me none of your business, I'm still on screen your immune system. It has nothing like for Black, especially looking at African American Black women. It don't got nothing to do with that. And HIV is not interested in our box. It's interested in immune systems. And so I need to, if the virus is interested in immune systems, that's what I need to tell the community, and that's what I need to tell my patients.
All right. So I want to say hey to Claude Robinson, who's here with us. Hey, Claude. Claude is here with us on this evening just as well. Krista Bonnie is here with us, and she says good evening to everyone. Arlene Spencer is here with us, and she says good evening. Tina Hammond is here. And not only does she say good evening, she's inviting other people to join. Audrey J. Cox is here, and she says good evening to everyone. And Mr. Brown is here, and he actually asked a question that Dr. Pete actually has already answered. So I want to say thank you for asking your question, and we actually covered that for you. Miss Sutton is here, and she says the Core Center. The Core Center is a great resource on the West Side for care and education and support for the community. We need more places like that. Thank you so very much, Miss Sutton, for sharing that. And I definitely want to say to our Core Center employees who are working right now, who are watching, they are working, but they are watching. Thank you for always being here on Monday nights. Linda Johnson is here. She says good evening. Ms. Sutton also said they provide medical, dental, and social services. So thank you so much for sharing those resources that the Core Center has. Nellie Purnell King is here, and she says, good evening to everyone. The Core Center is really a great, us in Congress, we fund the Core Center a lot. So I love the work that they do, and most of our FQA, actually all of our FQHCs, and additional healthcare places as well. Linda Johnson says, the emergency room test when you come in. So I think she's asking you, Dr. Maya, do they add that screening in your emergency room test when you come in?
Very rarely do they add that screening. I do want to give a shout out to the Core Center, because the Core Center developed early on a partnership with a lot of entities where you can get, like, they go out and train providers, like in the emergency room. When you see this come in, somebody came in telling you they got flu symptoms, add that to the battery, because one of the very common ways HIV presents is, I felt like I had the flu and then it went away. That, boom, that's it. So adding it, but very rarely is it added. There are a lot of entities doing the work to say, hey, emergency rooms, add it. Now, when we looked at studies to see why in the emergency room people weren't adding it, it's because a lot of times they're like, okay, so is it going to kill you now in the emergency room? No. So we're focused on that. And then the other reason was there wasn't a linkage to the back end. So the Core Center, a couple of other entities, Access, Howard Brown, a couple of entities build some back, like, go ahead, test the person. If it comes up, reactive, if you get a reactive result, meaning your body has been exposed to HIV, we can link them to care. Right now, gold standard, they're trying to link within, we try to get 24, some people 72-hour linkage to a medical provider, because the literature shows that if I'm diagnosed with HIV and I get into care early, I'm taking my medicines early, I have better outcomes. So building that infrastructure to help on the back end has greatly increased the number of emergency departments that are screening for HIV, but still there's more work to be done.
Yeah, absolutely. Go ahead, Pete.
Now, I'm just piggyback off of what Maya said. I think oftentimes the reluctancy also is that people don't know what to do when that test is positive. And so they feel almost handicapped. And so I think creating these partnerships where an HIV organization can partner with a ER to say, hey, we will take the patient. We'll have it's like built-in slots in our clinic to get the patients in if they come up HIV positive. And so then creating these partnerships where entities, we know the ER is really a place for triage. They want to know, are you going to die? And if you're going to die, are you going to die tonight or tomorrow or whatever? So they don't necessarily, that's not really the place, but it's just a unique place to get people who may not normally go to the doctor. And so that person that's in the ER, you know, if we can get that test done there, that might, you know, really diagnose them from, they might not have normally been diagnosed for the next 2 or 3 years because they may not come to the doctor. But if you're in there for a headache or chest pain, and if I know, if I'm an ER doctor, even though I'm not familiar with HIV medicine, but if I know we have this group over here from Howard Brown, and they are gonna guarantee that this patient is gonna be seen, you know, within 72 hours. Perfect, because that means I have a resource, which is really what ERs do. They triage. They shuffle the little chess men around the board. So that, and then I'll say this too, that I think when Dr. Meyer was talking about communication and the language, it's partly the reason why the HIV epidemic is as out of control in the South. If you think about some of the southern states, it's out of this world. Those states, HIV rates in those states rival some third world countries. We're talking about Mississippi, Alabama, Louisiana, all those states. It's because of their language that people are acting like people are not having sex there. So nobody wants to talk about it. You know, there's all these gag orders. I say gag orders, but it's not real. But in other words, people are not putting resources, necessary resources. I went to an international stigma conference in DC, and I talked to this group, and this group was from Jackson, Mississippi. So after our long debate about Deion Sanders, then we talked about, I said, now, so tell me what it's like. This is an HIV organization. And they said, we're not an HIV organization. We do whatever they did. But so in other words, they had to sneak and do HIV outreach. I said, now I'm not mad with them. Y'all doing what you're supposed to do. You have to get it done no matter what. But just imagine that for a second. We don't have to hide here. We can just say, hey, we're here to make sure, you know, that you are sexual, that we're taking care of your sexual health, and we're going to test you for HIV and any resources you need. If you have any STIs, they have some organization. I don't know what's the name of it. I don't know if they make bicycles or whatever. But then it was like, but really, we're testing for HIV and we're going out. We're going in all the community. So I'm saying to myself, that's one of the reasons why the South, why the outbreak is as bad as it is in the South, because they have these gag orders. And it's like what Dr. Meyer said. We're not having the right conversations. We don't have the right people having the right conversations, right? So those are all challenges that can increase the incidence of HIV.
Yeah, you know, the big issue is that in our society, we have a problem with dealing with something that's so common and so desired by the community. Everybody that's able and willing and desire to have sex is involved, but yet and still we act as though nobody's involved in it. And just to go back, you know, some years ago, when I first started practicing, the fact of it is that all sexually transmitted disease, people have a problem with discussing it. There was the same thing with gonorrhea and syphilis back in the earlier days. You know, people would come in and you would discuss these issues and make the diagnosis, and you would treat them. And then you would say, you know, ask them about their partners. And my goodness, it's like you just basically, you know, once you begin the conversation down that line about partners, now you created a big stop there kind of thing, because I don't want to get into that, or I don't want to discuss. Well, you know, you had sex with this person. Now you're the connection here. I know that you have a disease. I need to be, you know, to get this person diagnosed and treated or whatever. But that part of the conversation, which is going beyond yourself, has always seemingly been a problem with discussing the problem of sex. And with Black people, I mean, I find that that's even a more difficult issues to deal with in terms of discussing, complication from sexual transmitted disorders. And we I don't know. So that's when is how do we get beyond that? That's it's a problem that's been here a long time. But in order for us to really make the necessary changes to really impact the way that we would love to impact, we're going to have to get beyond that blockade.
Yeah.
And Dr.
Outstanding.
Ma, I got a question too.
Following questions. Some of these next following, I'm gonna come right to you in 1 second, Dr. Mason. Some of these next following questions actually kind of talks about that. But Pete, I got a quick. Well, I don't know if it's a question or a statement. I love the fact that you asked. People don't know what to do if they are told that they have HIV. Well, what do they do when they are told that they have cancer?
Yeah, that's a good point, Nikki. And I mean, like to Dr. Meyer's point, we've got to normalize treatment, normalize talking about it. People come in when they're concerned about cancer. They ask for cancer screening tests. We need to normalize people asking about an HIV screening test. We should do that. And again, it's all about how as those of us who deliver care, how are we presenting, so people can sense when I'm uncomfortable having a conversation with somebody. So the more uncomfortable the providers are and the nurses and the clerical staff, the more uncomfortable the patient's going to be, because they're thinking, why are you uncomfortable? Like, it's almost like, they say, when Black people, whenever we see somebody running, we start running too. Like we start running too. It's like, why are you uncomfortable? And should I be getting up out of here? And so we need to normalize it. We need to include it as part of taking care of our patients. So like Dr. Meyer said, like, I have a patient of mine, I ordered some labs for them, and the nurse called me and said, hey, this patient wants you to call him back. I called him back. He said, I don't know what kind of person you think I am. We had such a good relationship. Why would you think that I'm that kind of person? Now, I don't know. I'm like, what kind of, I'm thinking, did I mispronounce his name? I didn't know what I did. I said, wait a minute, let's start over. What is it that I did that you think that I missed? He said, you ordered this test. I was like, that's because I care about you. The same way I ordered the PSA and the lipid panel and the vitamin D. I said, I ordered that test because I care about you. It doesn't mean anything. It doesn't mean I'm judging you or anything like that. I say, and I had to, and really, because I get it, he thought I made a judgment on him, right? But this is what I'm looking at. He's a Black man in America, right? So much of his whole life, somebody's judged him, right? So I didn't feel like, oh, I'm like, hey, I get it. You're a Black man in America. I understand that. I also experienced judgment, right? When the police stop me or when someone thinks I'm stealing in a store or whatever. So I get it. I said, but listen, you amongst friends now. I'm trying to help you. And so by helping you, if that is to include this test, I said, but there's something called patient autonomy. He deserves the right for him to say, don't run that test on me. Now, if you want my advice, I say that would be ill-advised. But you do have patient autonomy. You can tell a provider that you don't want this or you don't want that. If I have some patients that don't want to see residents, don't want to see medical students, and I'm adamant about it. I'm like, nobody's gonna make anybody come in here. If you don't want nobody here but me, then that's what it is. But anyway, I'm just saying this to say that communications is important. Like Dr. Meyer said, we got to normalize it. It shouldn't be anything other than, oh yeah, I think I need a mammogram because my aunt just got breast cancer. Same thing. I think I need an HIV test, and you ain't got to tell me why.
Mhm.
But that's one thing that I wanted you to bring out was the fact that we needed to normalize it. And that's one of the things that I love about Dr. Mason. People may think I'm crazy when I say this, but Dr. Mason normalizes the penis. He knows
Yeah.
that all men has a penis. He
Yeah.
doesn't mind bringing up the word penis in the conversation. You
Yeah.
could be talking to Dr. Mason over some spaghetti, asking him to pass you the pepper, and he's going to mention a penis because he wants you to normalize the penis at the table, because he knows that all men have a penis and eventually a woman may see a penis. So he normalizes that conversation. Dr. Mason, go right ahead.
No, I mean, I think you're right, Nikki, to a large extent. One of the things I was going to ask is to that point, because it was the same thing that I had in practice when I was asking men about their sexual function. A lot of men did not like to answer the question about whether or not they were having problems getting and maintaining an erection. But if I don't know, then I don't know what to do. If I know, then I can say, well, these are the things that are available to you. And the question I was going to ask both Dr. Maya and Dr. Thomas, how do you, at what age, I mean, either what age and or what circumstance do you suggest that people have the HIV antibody test?
I think in any circumstance where someone's been exposed to a needle in a non-medical setting, and if someone's exposed to sexual contact, whether it is consensual or not consensual, and I do think, the guidelines say 13 to 64, and I think it's in the context again of immune system screening. It's not in the context of, like you did this, and if medical providers changed that, then I think we get further along. I always say, for those of people that read spiritual books, the correlation is, remember the leper, and they would put the leper on the outside of the city and all this other stuff, until we came up with a medicine called Dapsone. Now you don't hear about leprosy anymore, like things like that, right? HIV is like a modern day leprosy. And whether it's a physical outcasting or a social or sometimes spiritual outcasting, that is still happening, even though we have medications that offer people a long, healthy life, and not like the medication that you saw on what was that, Dallas Players Club or something like that, when they took the medication, they felt sick and they was throwing, not like that. We have once a day medications. Now we have injections you can take every other month and live a long, healthy life and live with HIV. Not only that, we have prevention medicines. The bottom line is HIV. I always say HIV is more, stigma is a disease of the mind. It's more infectious than HIV. Mm-hmm. It kills more people than HIV ever could. Stigma should be written down in that DSM book.
Yeah.
Because it is a horrible, it spreads like cancer. And stigma is when you believe something that's untrue so much that it impacts your way of being and will impact your life and your health. And that's what's going on in the Black community. Stigma is infecting our minds, and we're spreading it by the things we say. We're spreading it, like you said, Dr. Mason, in the things we don't say, by not making it kind of, in the conversations we have. Again, if you don't get anything, HIV is a virus that attacks the immune system of humans. Everybody listening with an immune system needs to get screened. So the guidelines say you start when they're 13, unless they've been exposed. So just to be clear, I have patients that acquired HIV from their parents, mother to baby, right? There are other ways HIV is spread. It's not one just spread solely through sexual contact, So being able to know somebody's history, you were exposed to the blood, the semen, anything, breast milk of someone living with HIV, you need to get screened. You were exposed to a needle. You stepped on a needle outside. You need to get screened for HIV, So it changes based on that, right? And then if you didn't step on any needles, you weren't exposed, and you start having a conversation about a person's immune system and protection when they're 13.
Outstanding. Joe Harrington, you've been itching.
Yeah, I just wanted to make a point, and it goes back because you brought up cancer. And I just want to let people know that they may be afraid to know their status, but at the same time, it can be too late to find out what your status is. That's the other side of the coin. If you wait, the longer you wait, the longer you may have a disease, and the less likely it is that a treatment can be applied that will get you to where you need to be. So that's why even sometimes bad news is good news, because you get an opportunity to do something to increase the likelihood that you'll live for a longer time. So that's something I think people need to hear. The other thing is, what's impressed me is the passion of my colleagues in talking about that. And I would hope that the people that are listening to this look at us as what I've heard said over and over again. Who are the trusted voices? We're trying to be those trusted voices. People that look like you, have experiences like you, know what you're going through, to tell you what we know based upon fact, based upon evidence. These are things that you should do. And I would encourage people to take what we say to heart and actually do what they need to do to protect themselves and protect other people.
Outstanding. Well, Dorothy Murphy says, does data back up the 1 out of 2 Black men being infected? And so does, Adam Murphy actually says, do you believe that 1 in 2 number?
All right. So I corrected. I think people may have misunderstood. I said Black men who have sex with men. So that's not Black men, period. It's Black men who have sex with men have a 50% risk for HIV, as opposed to Caucasian men who has a 1 in 16 risk. Caucasian men who have sex with men. Okay, so that was the missing piece there.
Okay. Adam also says, I don't see that in my patients, and I think it's because maybe he missed some of the verbiage that you may have said. And then he also asked the question of how do heterosexual men get this? And I think Maya actually went over that. She talked about how it could have been passed on from a parent. It could be needle use. She talked about a lot of those things, but did any of you want to say anything else to that point?
Yeah. Okay. Heterosexual men can, sorry.
No, go ahead.
Yeah.
Go ahead. Sorry.
No, I was just saying, I mean, if you're having sex, you could potentially have a risk for HIV if you're not using protection. It's not, it's pretty simple. And so that's why we don't put a stigma on it to say only these people should be tested. And, if you're unclear about your partner's history, and that means if you, there are many people who have to negotiate where they stay. They have to have sex in order to stay someplace. Those people probably should be tested more, right? But we don't put any sort of like criteria on it to say only these people can get HIV. That's not true. If you have unprotected sex, you can get HIV.
Sex is the most common way to get HIV. But as Maya pointed out, you could get a needle prick and get HIV.
Absolutely.
So you need to be aware that it's not just sex. I mean, that there are other ways to contract HIV. And you need to know your status.
Oh yeah. So Adam just said, no, he said, I mean, you said 87% of women who get it from a heterosexual sex with men. what percent of heterosexual men get it from heterosexual women partners? That's a,
Oh, Dr. Murphy, the percentage of men that get it from heterosexuals, I'll have to look that up. I don't, it is low. And it's a tissue that's the issue. It's the way it's spread during sex, right? So if I'm inserting a depositing fluid, I have a lower chance of getting it. The risk is still there. And if I'm on the end of receiving fluid into my body and fluid that kind of sits there, because HIV is also spread through semen and blood and things like that. But
And
let
there
me
are-
get that for
and
you, Doctor. What you say?
No, I was going to say there are some heterosexual men that claim to be heterosexual that are not just heterosexual as well.
yeah,
That's true.
that part.
So that's why I also focus on whether someone has an immune system,
Yeah.
because again, one of the ways, and this is something like, so HIV is I took an HIV medicine fellowship, and so it's providing HIV care is one of my passions, and to the point where I think of it as, what is this virus doing? How is it outsmarting our human tendencies, and how can I outsmart it? So I'm one of them people, I literally think about it as something I want to stop, and I'm sitting up thinking like, okay, it's then outsmarted us by getting us to put labels and, how somebody got it and and all this information that I really don't need. I need to know what the genetic makeup of the virus is, if the virus has any mutations, and what medicines work on the virus. And if you're a provider out there and it sounds weird, I'll bring you to this. One of the first things I learned as a medical student was culture and sensitivity of bacteria, where they sit there, they take a bacteria, they put a medicine in the presence of the bacteria, and they see if that bacteria can thrive in that medicine or not, or what medicines are going to work to kill what bacteria. Culture and sensitivity. Every time you go to the doctor and say, I got a urinary infection, they're going to run a urine culture, right? Looking at mutations of HIV. I just need to know if this HIV is going to thrive in the presence of that medicine. It's not complicated. It's the same thing as a culture and sensitivity. It's the same process. I just need to know what medicines are going to work and what's going on. I don't need to know how you got it. It does help us to understand how we can do prevention and who we need to focus on for prevention. So it does help if you share that. But I want to say, you don't have to share that to engage in care. You don't have to share that to get a test. You can literally come in, I'm going to provide, you can tell me none of your business. And I tell them, hey, before I start these questions, none of your business is I'm super open to. Right? Because HIV has outsmarted us because it's not thinking about that. We are.
I don't know what this is about, but there's so much cross chatter when people are talking that I'm hearing. So if anyone, only the person who's talking should have their mic unmuted. Everybody else should be muted when the other people, because I'm hearing all the conversations, I guess, coming through, especially if you have an open computer and the sound is coming through your speaker, you're picking that's being picked up. But I could barely understand what anybody was saying.
Yeah, we've had that as a little tech problem since we've started, and I don't know where it came from. It picks up and then it goes away. So yeah, I'm sorry about that. Let's see. We're going to move on because the hour is drawing near. Robert Douglas said, but thank you, Dr. Mason, for bringing it up, because some people have actually commented when certain people were talking, they were having some interference. But Robert Douglas says, we are lucky the greater community is disconnected from equitable engagement.
Did Nikki go out for everybody else?
Okay, there we go. So sorry about that. So Robert Douglas was saying we are lucky the greater community is disconnected from the equitable engagement. Carmen Pitts is here with us. She says hello to everyone. Dr. Pete was putting those statistics about the South in there to make sure that everyone had it and knew what was going on. Carmen Pitts Gibbs also says, we definitely need to start the conversation with our youth. safe sex, the outcome that may come after the entanglement. All right, the entanglement. Well, Adam got his question answered, so I thank you so very much, Adam. And I believe you and Dr. Pete were engaging via comment section here, and he also said, gotcha. So he left knowing, getting the information that he needed and saying thank you. So I thank you so very much, Dr. Murphy. Thank you a whole bunch. Our hour has drawn near, and I know you guys hate to hear me say this, but it's our time. I know. We can actually come in and continue to have some of this conversation again on next week, because we did get a number of questions that actually came in. So we did get a number of questions, so we can continue some of this conversation a little later. Want to go around the table as we always do and say our until next Mondays. Dr. Douglas Graham, what is your until next Monday? Pete, never sit next to me in church. Go right ahead, Doug.
My experience was the same as Dr. Mason's. In the 1980s, I was working in the cancer clinics, and that's where we saw the HIV patients. They had a very unusual skin disease called Kaposi sarcoma. And to me, it's really astonishing to see how much science has advanced to keep this disease under control. And from my perspective as a rheumatologist, it sounds like you do better with HIV than you do rheumatoid arthritis or lupus. So all I can do is just to encourage people to get information and to get connected, because this really makes a meaningful difference in longevity and the quality of your life.
Outstanding. Joseph Harrington, you're until next Monday.
Yeah, I'm going to put on my public health hat and talk about the fact that the flu is caused by the influenza virus, and we're having one of the worst flu seasons ever. COVID is caused by the coronavirus, and we're still fighting COVID. And AIDS is caused by the human immune deficiency virus. All of those we have treatments for. We have vaccines for each of those. The vaccines work. What you don't know can kill you. You need to know your status relative to each of the things that I mentioned. And there are treatments available for you if you do get sick. But you need to get that information as quickly as possible to lead a healthy life. And the reason you need to do it is not to protect yourself, but to protect the people you love from you.
All right, protect yourself. Know your status. Dr. Terry Mason, you're until next Monday.
Everybody having unprotected sex with anybody should get the test. Period.
I felt like that was a drop the mic moment. Okay, Dr. Mason. Dr. James Miller, you're until next Monday.
Well, this has been a conversation that hopefully has touched the ears of the community. And, we got to look at this in terms of what it really is. This conversation is really about. And it's about let's, take this outside of the box, in the sense that let's not look at HIV and start creating and start judging. But let's look at a disease that's harming people and say, what can we do to help to heal it? And part of that is that we can become more normal in our relationship with one another. We can become more active in our communication with each other, or just about caring and sharing and about helping each other. And so the community has to engage with this process. It's important that the providers provide the services that they've been trained to provide, but it is critical that the community also take an active role in communicating and really getting rid of the stigma and all this other stuff that's really blocking people from seeking the care that they need, or just doing the things that each individual need to do. Because as long as those things are there in our way, we are going to have trouble with some people not crossing that barrier because they don't want to be judged. They don't want to feel a certain way. And so that's something that we can help, that the community can help to heal that process and make this not about, what one may or may not be doing, but about the fact that we have a situation that we care, we love each other, and because of that, we're not going to judge, but we're going to do what we can in terms of communicating, in terms of relating with each other in a way that makes people feel comfortable with seeking what they need to seek.
Outstanding. Well, Kim Jackson says, thank you to everyone for sharing your insight. Dr. 100, you're until next Monday. That's right, Dr. Maya Green. Dr. 100, you're until next Monday.
I got a whole bunch of entails. I'm gonna try to keep it as brief as I can. Dr. Murphy, the answer to your question, the percentage of African American men who get HIV through heterosexual contact, 7%. I was able to find that on HIV.gov if anybody wants that information. Now, why are African American men? That's those stats that Dr. Pete said, right? PrEP, medicine that help protect your body. What percentage of African American people know about PrEP? 9%. What percentage of Latinx people know about and get PrEP? 9% get PrEP. 9% of eligible people get PrEP. 16% of eligible Latinx people get PrEP. 68% of eligible white people get PrEP. Right? Viral load suppression, meaning suppressing, we know undetectable is untransmittable. U equals U. It came out in 2000, I want to say 15. We know 0 times in history have a person living with HIV who took the medicines and suppressed the virus, transmitted it to their partner. What percentage of African American people living with HIV are suppressed? 65%. What percentage of Latinx people living with HIV are suppressed? 71%. What percentage of white people living with HIV are suppressed? 68%. African American men and women are more than 10 times more likely to die of HIV related illnesses than our white counterparts in a time where nobody has to die of HIV. I'm gonna leave it there, Nikki. I got so much to say, but
I think we may have to continue some of this conversation, at least a little bit of it next week, because we've gotten so many questions about it. Dr. Pete, you're until next Monday.
Yeah, I just, I don't know why Maya did that, because that just opens up a can of worms. It underscores what we've said from the time we started this forum, which is, there's so many factors that impact our health that people don't even talk about, that we act like it doesn't exist. The idea that social conditions that can keep you from controlling your blood sugar, that you live in food deserts, and we act like that has nothing to do with diabetes. That has nothing to do with the consumption of highly processed food. And so now, take it from HIV. There are many people who are at risk for HIV because of the social conditions that they live in: substance use, racism, poverty, even in the South. I mean, some of those rates down there, it's like we should, as a country, we should be ashamed of those rates of HIV there. And those are some of the same states that refused to take Medicaid expansion. Now, so you're in the worst shape of all the other states, and you don't want to take Obamacare or whatever. So it's just a saying, there's so many things that impact our health, including the HIV rates. And so we've got to combat these things on all fronts. But part of it is having providers who look like the community, who can have the right kind of conversation to engage and be respectful to the community, so that they know, okay, you're not trying to run some Ponzi scheme on me. You don't want to do some research on me. And those are the kind of things that we, again, not having enough discussion about, because you want Black patients to take PrEP, but you got most of their care is done by non-Black providers. Well, and it's not a matter of, it's just their lived experiences might say, okay, I trust my uncle, I trust my my dad, you know, and so I trust my aunt. So if my aunt walks through the door and say, "Hey, take this. This gonna help you," okay. So those are kind of discussions that I'm sure Dr. 100 will have, that I will have. I mean, and even in our examples of how we talk, you know, it's very it's more receptible to some members of our community. But definitely get tested. There's injectable medication that you can take that's 90. This works just as well as the pills. In fact, even better, because you know people might miss a pill here or there, but once that medicine is in your system, it's there for the next 2 months. So we have a lot of advancements, but we you know, I always tell my patients, you know, if you don't take the medicine can't work on the shelf. If you don't take it, once you take it, then it can work. I'll say so. But that's all I gotta say.
All right. Well, just want to share that the congressman could not be here with us on this evening. There are a lot of things going on in DC today, and he could not be here. But he wanted everybody to know that he was thinking of you, and he says hello, and he can't wait to get back with you on next week. Also, want to remind everyone here to be a part of the trend. Make sure you take that new trendy COVID vaccine. Want to make sure that you're healthy. So make sure that you're a part of the trend. You know you want to have the latest, so make sure you have the latest vaccine. And then before we go, I want to make sure that I tell you that today, there are more than 1.2 million people living with HIV in the US. And as Dr. Pete shared earlier, there are more than 35,000 new infections each year. More than 700,000 people in the US have died from HIV-related illnesses. Pre-exposed prophylaxis, PrEP, saves lives. It's a highly effective medication when it's taken properly. So you can't leave it on the shelf. When it is taken as prescribed, it is highly effective. And yes, PrEP reduces risk of getting HIV in cases of sexual contacts at about 99%. And it also reduces the risk of getting HIV with injectable IV drug users at least 74%. Today, we stand in solidarity with people around the world who are affected with HIV. Today, we also raise our voices to unite by sharing these experiences, educating our communities, remembering those lost, and standing together to fight against HIV. And most of all, continuing to do the work and to raise awareness. Remember, true wealth is health. Until next week, see you then. Bye now.